for all the panelists, now the other participants are coming in. You can say hi to them in the chat box. Right? Rasuki Kuroda is now in. They say hi to all of us, right? Okay. Good evening, all the friends from Asia, right? So I'm Professor Patrick Young, moderating this FCAS ACAT webinars for surgical tricks for managing patellar instability with my colleagues and friends, Dr. Dave Lee from Singapore. This topic regarding patellar instability is indeed planned by our very good friends, Professor Feng Hua from Jisui Time Hospitals about 2 months back, right? Most of you probably know that he left us about 3 weeks ago. So before we start this webinar, we would like to have a memorial videos for our good friends, Professor Feng Hua, to share with you, which is presented by all his friends and different international sports medicine organizations. Okay. Without any doubt, Professor Feng Hua is indeed the master in knee surgery, particular interest in patellar instability. I'm pretty sure this group of friends from ACAT and EPCAS will try our very best to continue the legacy of Professor Feng Hua in nurturing and teaching to young people, right? So without further delay, we'll kickstart this webinar on patellar instability. I would like to invite my partner, Dr. Dave Lee, to introduce our coming speakers today.
Yeah, good evening. Hi, I'm Dave from Singapore. So this evening we have 5 speakers, and the first would be Professor Adachi from Hiroshima University, Professor Yoon from Kyung-hee University from Korea, Professor Chan from Chang Kung Memorial in Taiwan, Professor James Sui from National University Hospital in Singapore, and finally Professor Chang Hui from Ji Shui Tan Hospital in Beijing, China. So we will start off with the talk by Professor Adachi. He's going to tell us. Yeah. Okay. Yeah. I think Patrick will introduce.
Yeah. So Noble, while you are preparing to put up the slide, I just say a few words about you, right? Please share your screen. So Professor Noble Adachi is the chairman of the Department of Orthopedic Surgery in Hiroshima University, which probably a lot of us know about him. He's like one of the master in Japan in knee surgery. So he is today going to share with us his experience in doing managing patellar instability. So Noble, your turn. Thanks.
Okay, thank you. Can you see my slides?
Yes.
Okay. First, please look at the different axial views of plane radiograph of the same patient. Knee flexion angles are almost same, but the patellar shift and tilt are so different. So how does it happen? The answer is those axial images are taken by different imaging protocols, a skyline view and merchant view. And Nordic evaluated an axial radiograph at 7 different outpatient clinics using phantom leg and reported that the radiographic protocol for knee axial imaging are inconsistent in radiograph positioning and imaging. This variability can lead to disparity in radiographic image results used for clinical decision making. We also compared the axial imaging of patella with the skyline view and merchant view for those parameters, congruence angle, lateral patellar displacement, and lateral patellar femoral angle. These are the results of at 30 degree knee flexion. The congruence angle and lateral patellar femoral angle are significantly different between the imaging techniques. And those are the results at 45 degrees knee flexion. As you can see, the merchant view always showed greater patellar instability than skyline view. Therefore, we should be very careful when comparing the radiographic results of different clinics or interpreting the published reports. As for the axial imaging of the patella, assessment of the dynamic patellar instability is very important. We have used quantitative stress radiography of the patella for evaluating dynamic instability. Some patients demonstrate very high mobile patella, while some patients show very tight patella. Therefore, we must pay attention to the dynamic patellar instability for diagnosis and to determine the surgical procedures. Our colleague, Dr. Nimoto, used this quantitative stress radiography and evaluated the patellar laxity before and after lateral release for recurrent dislocation patella. Very interestingly, they reported that the lateral release significantly increases lateral but not medial laxity in patients with recurrent patellar dislocation. Therefore, we should be very careful about doing only lateral release for some patients with recurrent patellar dislocation because this procedure can increase lateral instability of the patella. TTTG indicates lateralized tibial tuberosity or medialized trochlear group, usually TTG distance of more than 20 millimeter is believed to be associated with patellar instability. However, special concerns associated with the measurement of TTTG distance include knee rotation, knee flexion, and trochlear dysplasia. On the other hand, TTPCL distance is not influenced by these factors. The distance can be measured on standard MRI of tibia alone. TTPCL distance using MRI has been reported from Western countries. Several reports have revealed a large difference in height between countries and ethnicities, suggesting the possibility that abnormal TTPCL distance could be shorter in Asian patients due to the knee size and height. A TTPCL distance should be adjusted according to the patient size in order to evaluate patient-specific TT lateralization. We included 41 Japanese recurrent patellar patient and matched 41 control group. We measured the TTPCL tibia width and the TTPCL distance tibia width ratio. Although a small 0.6 millimeter and non-significant difference of TTPCL distance was observed between groups, the TTPCL ratio was significantly larger in patellar dislocation group. There are weak and moderate positive correlations between the TTPCL distance and the patient size, and no correlation was found between the TTPCL ratio and patient size. So based on our findings on decision-making in distal realignment surgery in patients with patellar instability, using TTPCL distance alone carries a risk of misleading false indication compared with the TT lateralization. Through TT lateralization, our results suggest that the TTPCL ratio has the potential to identify patients with patellar dislocation and TT lateralization that particularly contribute to their pathology, and threshold of TTPCL ratio 34% may be a reliable decision-making criteria for distal realignment surgery. Now I'm moving on to the NPFL. As you know, the NPFL is a thin fascial band that links from the medial epicondyle of the femur and to the proximal part of the medial border of patella. It was reported that the mean failure load of the NPFL was 208 Newton, and NPFL function like an anchor to prevent the patella to move excessively laterally, like this video. We have performed SEMT transfer for the patient with the open faces not to damage the growth plate and SEMT graft for the adult patients using bone socket procedure. They reported a clinical outcome after NPFL reconstruction with tendon transfer in 2005. This study includes not only young patients but adult patients. They reported favorable clinical results after this procedure shown in the radiographic and clinical improvements. They also reported clinical outcome of the after NPFL reconstruction with tendon graft. They also reported favorable clinical results after tendon graft, except one case of the persistent medial instability treated by lateral retinacular reconstruction. When performing SEMT graft for reconstruction, patellar side is fixed with the soft tissue suture and femur side is fixed with bone plug. For graft insertion point, patella 2/3 of the proximal medial edge. However, femur side, we have used the arrowhead points as the original NPFL insertion position. However, still our question is where and how we can decide the femoral insertion point. Everybody knows the Shutter's point for femoral fixation point. Several authors stated that the Shutter's point is the most used method for NPFL reconstruction in clinical practice. The architects company provides NPFL to determine the shutter's point easily intraoperatively under fluoroscopy. However, shutter point is based on the only cadaver. As you know, the recurrent patellar dislocation patients has several abnormal anatomic factors. Therefore, these predisposing anatomic factors might have the potential to affect the anatomy of the NPFL femoral insertion side. So our clinical question is whether NPFL femoral footprint in healthy knee is equal to the recurrent patellar dislocation knee or not. To answer this question, we came up to a new method for radiological identification of the NPFL femoral footprint. We reconstruct a virtual radiograph from 3D CT. Using this method, we will be able to obtain anatomical femoral insertion of NPFL in virtual radiograph. To identify the femoral insertion of the NPFL, we follow the Fujino's method, 10 millimeter distal to the adductor tubercle. And from pre-op CT, we reconstruct 3D model using this software. And then we obtain true lateral view of this screen. Next, we mark the point with marker according to the adductor tubercle like this. Finally, with this information, we modify the opacity to reconstruct the virtual radiograph using this software like this. We had a recurrent patellar dislocation in the ACL group. Recurrent patellar dislocation group has 26 patients with 29 affected knees who underwent NPFL reconstruction. From ACL group, age and gender matched patients are recruited, and this is no significant difference between the two groups in age, gender, and affected side. This is the results. All the points of the two groups and the shoulder's point were shown in this graph. The green point is shoulder's point, and recurrent patellar dislocation patient led demonstrate more posterior and distal portion. And the ACL group, blue indicates the almost patients also demonstrate more posterior and distal portion, but some patients include a shoulder's point. Again, the NPFL foot point in the recurrent patellar dislocation needs more posterior and more distal. So our method enables us to identify adductor tubercle precisely from the bony surface and anatomy and soft tissue information, adductor magnus tendon. And this information can be transferred to the virtual radiograph. So we can produce individualized identification of the femoral footprint of the NPFL in lateral radiograph. And these are the fusion images of the pre-op and post-op CT. Blue indicates the post-op CT like this. The patella is reduced very successfully. And if we're looking at the medial side, the point is here and the fixation point is here. And this is grafted tendon. So in conclusion, we should be very careful about imaging of patellar instability, especially by axial view on radiograph. Second, for NPFL reconstruction, femoral fixation point should be determined individual anatomical landmark. Thank you very much for your attention. And see you all in Pattaya, Thailand, and again in December. Thank you.
Thank you, Noble. Right, I think it's very important to know about all these fundamentals, anatomies, as well as the radiological imaging technique, because a bit of variations will cause a lot of difference in terms of the interpretations. Right. So, Dave, your turn.
Yeah. Okay. Next, we'll have Professor Yoon Kyung-ho from Seoul. He's the chairman, Department of Orthopaedic Surgery in Kyung-Hoo University. He's going to tell us about the ideal femoral position in NPFL reconstruction. So it's going to be quite similar to the previous one, but his understanding on the femoral position of NPFL. Thank you.
Hi, hi, my friend. I'm Kyung-Ho Yoon. So I want to talk about ideal femoral fixation position of NPFL reconstruction. As you know, patellar instability are classified into the three categories: major, objective, and potential. Then, what are the associated abnormalities? They are often called predisposing factors. So these consist of limb malalignment, or abnormal articular geometry, and abnormal muscle and soft tissue restraint, especially thumb medial patellofemoral ligament tear. So to treat patellar instability, these predisposing factors must be evaluated slowly, and the corresponding treatment plan should be made. Up to now, more than 100 different operations have been described for treatment of patellar instability. However, there is no gold standard treatment for patellar instability. Among the various treatments, what attracted my interest was the NPFL reconstruction. So I managed the NPFL reconstruction. Previously, I was interested in graft or fixation method. So my study compared the clinical result of NPFL reconstruction between suture anchor and transosseous fixation method on patellar instability. In the result, no statistically significant difference between two methods. However, there are two patellar fractures among the 20 patients of transosseous group. So I recommend that suture anchor fixation on patellar insertion would be better than transosseous method. And nowadays, my current interest moved into the fixation position of NPFL at both femur. In respect of patellar insertion of NPFL, anatomic studies mostly suggest the posterior medial part of patellar. I also used the vastus medialis tendon as a landmark because the patellar position is quite reproducible. However, what about the femoral fixation position of NPFL? I'm not sure that which point would be most suitable or reproducible and easy to do. So many surgeons have been using the shutter point. Already, Dr. Adachi mentioned this, but sometimes even minimal change of rotational angle, the femoral position can be made inaccurately. That completely so reproduce this point, but it's very difficult to so then where is anatomy femoral insertion of NPFL? A systemic review of cadaveric studies suggested that NPFL is our prostate. So NPFL has a broad insertion between the adductor tubercle and medial epicondyle. So if so, among the kind of broad femoral insertion of NPFL, which anatomic position is ideal for the reconstruction. So biomechanical studies show that two proximal and posterior position the femoral fixation of NPFL graft while NPFL reconstruction can dramatically overload the medial cartilage of patella. And another, on the other hand, the isometric study reported that NPFL is an isometric structure, and among the anatomic position, most isometric point would be posterior and proximal to anatomic femoral attachment. Both studies are indicating the proximal and posterior direction of femoral fixation position, but they suggest quite different point of view. Back to the topic among the broader femoral insertion of NPFL, which anatomic position is ideal for the reconstruction. Many surgeons use adductor tubercle or medial epicondyle as an anatomical landmark to make a femoral position of NPFL graft. You can identify this landmark well on the 3D CT images and categorize the femoral fixation position into two groups, proximal and distal group. So which group would be better? Previous, I carried out a study on the similar topic regarding axial graft position. I thought that most isometric position among the broad anatomy femoral footprint of the axial graft would be best for graft healing because it has a least change in the length and tension. After confirming the graft signal through the MRI, I'm trying to target the intermediate or center position of femoral insertion while performing axial reconstruction. So I adopted this study as a reference and made the first hypothesis. Clinical outcome of proximal group will be better than distal group. And second, my hypothesis is concerning the radiographic outcome. The study reported the patellar height decreased after NPFL reconstruction. Then, would patellar height be different between two groups, the proximal and distal group? My second hypothesis is that patellar height would not be different between two groups. So these two questions, I compared the clinical and radiological outcome between proximal and distal group. So 31 patients enrolled and divided two groups, 15 proximal group and 16 distal group according to the location of the femoral fixation group, fixation position. So no graphics is that there is no any significant difference except the male and female ratio. The surgical procedure, I usually use the allograft, the tibialis anterior, and then to split tendon to the patellar tendon. The patellar tendon is the landmark is with vastus medialis, and then femoral position is always approached the skin and the fascia, and exposed to the medial condyle and above the tubercle. So that is my best idea of the tunnel. So this fixation position is real proximal. Distal position is here. So we clinically and radiologically evaluated the result. But there is no significant difference between pre and post-operative scores, both two groups. And second result is yes, no differences between two groups. And then concerning post-operative patellar height change, so it showed no significant difference between injured knee and normal or contralateral knee at post-operative 2 years. So height difference change was not a thing between two groups. Then we checked the MRI and post-operative 1 year and evaluated in 3 positions: the patellar insertion and mid substance and femoral insertion. And result, proximal group showed better signals on patellar insertion of NPFL group. So we concluded that the proximal femoral fixation group did not show better clinical outcomes than this group, and 2 groups did not show any difference in patellar height. And finally, proximal group had better graft signal intensity on MRI than that of distal group. So it's my take-home message. There are a number of predisposing factors that contribute to patellar instability. For treated these patients, it's important to check soft tissue and articular geometry factors related to the patellar and over lower limb alignment. So in my cases, so treatment plan should be made by depending on this factor. In case of Jenny Bargo, I addressed this femoral pars, osteotomy, and NPFL reconstruction. And then in case of external tibial torsion or laterally poisoned tibial tuberosity, perform the tibial local transfer and NPFL reconstruction. And then in acute dislocation with condylar fragment and treatment as a condylar fixation and repair of the medial patellar femoral ligament in patellar detached point. And patellar dislocation or so patellar instability without any anatomic abnormality, I consider the NPFL reconstruction. And then the NPFL graft should be placed in between capsule and the arm. So thank you for your attention. So don't forget that the meeting of the COSM and APCAS.
Okay.
Thank you.
Thank you very much. So again, it's very important from both speakers, we understand that the anatomy and the footprint of the NPFL, particularly on the femoral side, is still one of the major concerns, right? So let's listen to further more speakers and see how they look at this, right? The next speaker is Professor Chen Yishan from Chang'an Memorial Hospital and the Chang'an University College of Medicine of Taipei. So he's the chairman of the Department of Orthopaedics, right? And today he is going to share with us about the techniques and the pitfalls in NPFL reconstruction. So Yishan, are you ready? Yishan? Yeah, you have to unmute your...
Okay, the voice okay?
Yeah, very good.
Okay, let's show my slides.
Yes. Perfect, we can see the slide.
Hey, good friend, I'm Dr. Chen from Taiwan. My topic is about technical pitfall for NPFL reconstruction using semi-tendinous autograft for recurrent patellar dislocation. I'm from Chang'an Memorial Hospital, the largest health system in Taiwan. My indication for NPFL reconstruction, of course, the patient has a symptom about patellar instability for acute or sports, partial apprehend test, and consider failure with the not indication for like a PFOA or patellar femoral theory without instability. So when I do the NPFL alone, if the patient just combine like mild tracheal dysphagia type A or B, or Q angle less than 20 degrees, and the TTTG like Boyong and Adachi mentioned about less than 20 millimeter, and the patellar from the CDI index less than 1.2. If more than 1.2, I will perform distal tibial tibal transfer first. As our speaker mentioned about patellar femoral instability, not only in the NPFL problem, you must evaluate very clearly about soft tissue or in the bone procedure before or combined with the NPFL reconstruction. That's very important for the diagnosis and the very clear indications. There's a key point about NPFL reconstruction. There were 5 procedures very important. The first one is the patella placement and the fixation. As mentioned before, the different technique of a patella attached to the graft patella and the locking, ducking or suture anchor or anchor attached graft to the patella, usually suture anchor or suture to the retina. A lot of method, like a transosseous method or use a suture anchor. I personally prefer use a single transpatellar tunnel technique fixation. From this portal, just use one intermittent screw. It's easier, and you don't need the other suture anchor for extra pay from the patients. In my personal preference, I use this one for jamming about this 5 diameter in the patella side, about proximal and the middle cell patella, and with a 5 millimeter limber in diameter about half the patella, and drill the other second tunnel from the center, connect to tunnel together and loop in the patella for like these pictures, the single transpatellar tunnel technique. About paper review about patella fracture, about 30.6 fracture and about 40% of major complication when use like a 4.5 patella tunnel. So for drilling the small, should be use small tunnel without the convergence, where avoiding transverse drilling will decrease the risk of such complications. At least my series no any complication like a patella fracture. So the second one is the femoral placement and the fixation. Professor Yo and Adachi mentioned about technique about a lot. So for femoral side attach, you can use a ducting into tunnel, suture anchor, or use a most common use the intermittent screw. For a skeletal immature patient, you can use a loop graft around the ductal maker tendons. About the most critical technique for NPFL reconstruction is anatomic femoral graft placement. As we mentioned before, we can use a palpation of also landmark and use a radiograph measurements. Dr. Nomura study about before it showed the anatomy position of NPFL in the femoral side, just about distal to the adductor typical or superior posterior to the medial femoral epicondyles. So you can identify from the during a small incision and palpate for the adductor typical and the medial epicondyle to set up the femoral side insertion of NPFL. Of course, you combine with the C-arm check. A second one is the radiograph machine that we mentioned before. A shuttle point is very popular and my personal preferred method, which can show very consistent placement of femoral tunnel within about 5 meters in the femoral anatomy side of isometry. Of course, we must make a true lateral graft. Like the picture of the true lateral, you can show the both condyle in the same curve. If some a mild internal rotation, you can see the red lines that mean the medial femoral condyle. Is the blue line show the lateral condyle. If a little bit external rotation is here is a lateral femoral condyle, so make sure it's a true lateral view. So it is very popular for a shuttle point. You can see the position. The line just posterior cortex is a blue line with a red line, and the curve of posterior condyle is this location is about NPFL femoral side in the insertion. Is from the shuttle point. So let's show X-ray true lateral view from compare with anatomy position. So this is a common mark position, 2 anteriors. So it's a normal side for the normal NPFL femoral side insertion. It's a lot of case report as 2 mark position. They show the correct NPFL in the same case. So sir, after tunnel, you can try the other method for isometric setting for NPFL reconstruction. If I confirm your tunnel from either anatomical or from the X-ray, you can pin in and your tendon graft from patella to femoral side and looking on the KY and knee flexion extension to check any motion of tendon. You can sure check for your position. It's a good position for isolation and anatomy for the NPFL for femoral side insertions. About the graft selection, we mentioned about from ortho and allo. Ortho about 70 and the graft series. Graft selection from the ultimate load, all the about 70 facilata graft is stronger, stiff, and stronger than native NPFL. About system review, compared with a lot of study, they conclude about for the NPFL reconstruction, the semi-tender graft is better than the graft series for the recurrent patellar femoral instability. About the knee flexion angle for fixation, Currently, there's a lack of consensus regarding the ideal fixation angle, range about 30 to 60 during NPFL fixations. Dr. Nomura, a long time ago, he published a study for cadaver showed the NPFL in this great tension and knee flexion about 0 and 60 degrees. Dr. Lopras group also mentioned about the same study. The study showed the cadaver damage, the NPFL fixation and 60-degree fixation could achieve patellar femoral contact pressure most compared to the lateral intact knees. So about graft tension, the upper tension required, I think a lot of people reviewed some most concerned about the tension about 2 Newton or just 0.5 pound. You can use one tension spacer near the tendon in the knee femoral side with a tension about 2 Newton. I know 2 or 3 is a very objective, but you can compare with the other mentioned later. So my preferred NPFL fixation about 60-degree fixation is easy to create a position of patella with the center of femoral trochlea, and in this degree of fixation, we can decide the proper tension of a tendon graft, and also combine with a dynamic arthroscope to check any in the patella positions, over tightening or insufficient or weak for the tension fixations. So this is before NPFL reconstruction, different angle, and after NPFL, we can during operation with the dynamic scope check the position, make your final position with the proper tensions. The proper tension graph can be assessed, but the other way is when you fix the tension or graph, you can keep knee in full extension. Ideal tension should be the patella can be pushed later about 1 centimeter. That means the patella not too tight or not too loose. This is the other practical way to check. This is my patient, 30-year-old female with recurrent patella dislocation for 2 more years. QN goes 15, TD 12, and CDI 1.2. So even self-fixed the patella to lateral side. I can check scope first. The case very tight, I said do some release gently, but not every case need a release. I must emphasize. So I have the same tendon graft, same procedure. The patella tendon here, like I mentioned before, and the fixed 60-degree and the scope check position, and after check for motion to see the proper tension after the procedure I mentioned before. So this after the middle side, lateral side is a NPFL tendon here. It's and the final is a bioscope fixation. The final is a photo show the procedure like this one. Before and after surgery, 2 years, it's good functional result. The other case send the patella, so NPFL reconstruction. So after follow for 2 years. The rehab protocol, first week, the concept for like weight bearing, isometric training, about week 2 to 4, and we can range motion improve to 90 degree, and the week 4 to 6, about 120 degree flexions. Cross chain exercise, about 2 months can steering, bicycling, and about 6 months can return to normal activities. So in summary, we should recognize the importance of bony alignment, like tibial trochlea, TTG distance, patella arter, trochlea, dispel, and the femoral origin of the mid-patella ligament importance. And the NPFL reconstruction requires very precise graft placement and the minimal graft tensions. So we must pre-workup a combination of procedure to assess abnormal morphology. Very special for the anatomy femoral insertion side, you can use 3 methods, also landmark or the shuttle point, or like a Professor Yo or others, some mentioned before, and use a isometric test and the scope check for any proper or any adequate tension for the femoral insertion sites, and the safe the secure patella fixation and appropriate graft length fixation, and the sort for knee flexion during fixations. About system review, about 3 major patella fixation graft about suture anchor, tunnel technique, and transosseous. If you put the procedure, as I mentioned before, actually in any kind of method, the very low extent of recurrent instability and the possibility apprehension and the rehabilitation rate, and the special notion difference in outcome is score or above between this method before. It's my presentation. Thank you.
Thank you, Ishan. That's a very nice summary of patella, recurrent patella instability. We'll move on to the next talk, but before the next talk, I'm just going to ask the 3 panelists who just spoke with regards to NPFL reconstruction, Nobo, Kyung Ho, and Ishan, do you all use one tunnel in the patella or two tunnels in the patella? So let's start with Nobo.
Yes, for the patellar fixation, we always fix the semi-T tendon on the surface of the patella, suturing the tendon to the periosteum. So we don't use the bone tunnel techniques.
Okay, and you have just one limb of the graft.
Pardon me?
You only have one, just one, no two limbs, just one limb of the graft?
Two limbs.
Two limbs, okay.
Yeah,
How about
two
Kyung Ho?
bundles.
Two bundles.
Yeah.
Yeah.
And in my previous surgeries, I used the transosseous tunnel for to tunnel, but I mentioned about that. So I reported the case of fracture of the patella. After that, I changed my mind, and then I used make the one tunnel in the superior medial portion, and then suture the graft to the osteotomy insert. So I always used one tunnel in patella.
One tunnel, one bundle.
One tunnel, one bundle. Yeah.
Okay. Ishan, you said one tunnel and one bundle, right, in your presentation? Okay, I think we'll let James start. The next speaker is Professor James Hui. He's the head of Department of Orthopaedic Surgery in National University Hospital, Singapore. We're going to switch tack a bit. He's going to tell us about fixing habitual patellar dislocation, how I do it. He's going to talk about a bit more of the adolescent or the younger patellar instability. Thank you, James. You can start.
Can I share my screen?
Yeah, yes, you can. Thank you.
Yeah.
Okay.
Is it clear with you, Dave? All right. Good evening, everyone. So we switch gear on habitual patellar dislocation. Well, patella is the reason why I first met Professor Feng Hua 12 years ago in Jishuitan in Beijing. And we are so fortunate to have the last meeting at SOA before the virus started last year. And Dave and I also, with him, witnessed the last legitimate match of Maria Sharapova before she was banned for drug cheating. So classification of patellar dislocation, especially in children and adolescents, is a little bit confusing, and the nomenclature sort of change with time. It's very clear in congenital patellar dislocation. It's something that we all know right above, and most of us won't deal with it. But later, the other classification a little bit confusing because the old literature tend to call either obligatory or habitual whenever patellar dislocate in flexion. So they call it habitual dislocation. But yet today we also know that there are a lot of so-called habitual dislocation in extension, and especially in cases that's atraumatic but a lot of J sign positive. Of course, so far all the three speakers mainly talking about those acute traumatic and then with recurrent patella. And finally, in cases where patella become really bad and chronic, they become permanent dislocated.
Okay, go.
So classically, in younger children, this is something you like. Okay. Whenever a child flex the knee, and he will get a dislocation of the patella. And essentially, the problem here is quadricep length problem. So usually, that's the one need to be addressed. So classically, you get to see CT, especially in flexion, you get the patella dislocate laterally. And that's how clinically patient will present. Sometimes they just unilateral, sometimes can be bilateral, especially in syndromic patients. So in literature, you know, Rugo wave is one of the most well utilized, and Gillespie technique was the one that actually with a semitendinosus tendon being used in the children. So that's how it's like. And as I mentioned, the quadricep length is the main problem. Therefore, we always do one form or another of quadricep lengthening, and in this case it was a VY. And having done that, when you flex the knee, then you can do your Rugo wave distally. So this is how another case is like. After your VY plus T, and you flex your knee down to 90 degree, and you can see that the patellar tendon, because the fact that in such children, even their TTTG was increased way under the age group of like 12 or 13. And you can see that before fascial close, the patellar tendon insertion is very, very lateral. That's why you need to split the tendon and then pass the tendon underneath the medial patellar tendon, medial half of patellar tendon, and try to suture into the tibia periosteum. And in the meantime, you also done a VY-plasty and then advance the vastus medialis. And that's how VMO being come up, and then you get to suture under it. And this creates a very, very strong and stable complex. And bear in mind, you must always fix it in at least beyond 45 degrees of flexion. Otherwise, when you take off everything and patients start to move, you find that if flex again, they may dislocate. And it's very important that in children, even though you have like 60 degrees of flexion, you will not have quadricep weakness or extension lag in the future. Somehow kids manage to recover this very well. So this is one of the case of the nail patellar syndrome, where patient actually has bilateral. So in this case, you can see after the procedure, you get very nicely relocated in the center. And classically, I didn't have the post-op picture. So that's how a habitual dislocation infection is dealt with. Now move on another clinical scenario in extension. So this is patient who presented actually with patellar dislocation, but totally atraumatic, never have any significant trauma in her life, but she will fall frequently, and when she participates in sports, she will dislocate. So in such patients, a little bit like in those extreme cases of recurrent dislocation, we really need to look at the patient as a whole. And meaning as a whole, look all the way from femur proximally and tibia distally. So first we look at, is there adequate femoral anteversion? If there's too much, you may have to do derotation or osteotomy. And is that terrible trochlear dysplasia? Then we may have to move on to groove deepening procedure for a trochleoplasty. So is there excessive Q angle, give rise to genu valgum, and you may have to do a corrective osteotomy. And coming down, the patella itself, so medially is NPFL very insufficient, then you may have to do MPL reconstruction. And look at the patella, was it very alta, very high? So you may have to distalize it. And laterally, it's where there's a lot of contracture, so which cause extreme tilt and extreme lateral subluxation. Then you may have to do a release here. And coming down to tibia is that there's excessive tibial torsion, derotation may be performed. And I think this will be covered by Professor Zhang Hui later. But of course, our favorite topic here is TTTG increase, and it may have to be medialized. So having analyzed every patient, then we deal with them separately. And one of the most significant one was in the study we did, 124 patients, measuring all their congruent angle and trochlear. We find that trochlear dysplasia in various degrees of severity between A to D was the single most significant predator of recurrent patellar dislocation in children and adolescents. So what's trochlear dysplasia? Classically, you get to see X-ray changes on crossing sign that you can see here, and also double contour sign. And especially in bad cases, you get supratrochlear spur. And this one probably the one that we tend to address surgically, and that's what you call type D in the digital classification. And this sometimes can be confirmed by CT scan and MRI. So another case presentation, 18-year-old, repeated dislocation of both patellae since 10 years old. Again, as mentioned, atraumatic, but yet frequent falls and even on standing straight and knees to giving way, running and walking. So classically, patient will present either like this, or you can see on operating table, the moment you flex is okay, but extend, you will just dislocate laterally. And as you mentioned before, even merchant's view or skyline view, you may have a almost normal kind of sulcus angle, only slightly shallow, and you will not pick up trochlear dysplasia on X-ray in this way. But on AP view, you begin to be very suspicious because patella was laterally sublux. And if it's done properly, a good lateral view, you get to pick up all these supra-trochlear spur to tell you this would be a form of trochlear dysplasia. So again, confirmed here on digital classification. And how to deal with this patient, having solved all, all the issues, there's TTTG wrong and a trochlear is not right. So that's what we do. First, we would do a tibio-tubical transfer. Before you transfer, you use it to open up as an access for your trochleoplasty. So we open up tibio-tuberosity, and with an intact medial soft tissue flap. Essentially, it's a form of M3 trila, because this is not focusing in adults. So here you preserve all your blood supply medially. And then when you open up and you expose, you really get to see this huge bump, that digital type 4, type D, which correspond to the supratrochlear spur. And of course, this is digital, but as you know that his father is the one that coined all the terms and classification in digital classification. So then you do this open door technique with intact hinge inferiorly without breaking the cartilage. And you do a so-called groove deepening, meaning you create a huge trough underneath. And bear in mind, must really preserve the vascularity of cartilage and subchondral bone above. And Arthrex has a device that so-called 3 milliliter burr, which allow us to burr the surface and without getting the cartilage too thin and without puncturing the cartilage flap. And I used to tell my resident, use an iPhone shining on the other side to see how thin it is, because getting too thin, of course, you get avascular, but too thick, you will not be able to press your cartilage flap down to do a trochleoplasty. So at the end, we'll do this using a bioabsorbable pin to pin back the flap. And this is out the end, and this is a before and after. So after that, we still had to do to complete the TTO, and also using NPFL as a restraint to just keep everything in place. And this is what it's like at the end of the surgery. And you can see that we flex and extend, both are extremely stable. And this is what's like immediate post-op. You check the X-ray to look at all your NPFL position, TTO, and also tracheoplasty cut. And this is 3 months post-op, everything had united. So we'll do a CT scan to check whether our tracheoplasty has really created the groove instead of the hump you saw previously. But you can see that a lot of time, you find a very uneven tracheoplasty groove coming in. And in literature, people will say that, they will say that just tracheoplasty alone, you shifted the trochlear groove naturally. Therefore, you don't need to do TTO to correspond it distally. However, there are cases, people have published that when they did this so-called tracheoplasty just proximally, but may not be able to correct the TTTG distance distally. So something you need to look at it very critically. And in removal of the screw, sometimes we ask patient, do you mind if we have a second look arthroscopy of your tracheoplasty? So this is fortunate we get to see some of these results of that. But I must say it's very humbling experience that even though you took all the care, but you find that the cartilage surface of the groove that you created are not as intact as all your surrounding innate cartilage. So tracheoplasty is a pretty hazardous procedure. So last scenario, we have those cases where patient had initially presented with flexion, then later gradually become so chronic and then it became permanent. So this patient will have extension leg, and since childhood, again, it's atraumatic and finally become permanent. So you get patient like this, you know, on AP weight bearing, you already start to see it really coming down very peripheral, and you can see when patient laterally and flex, you don't even see patella here. The reason is on skyline view, the patella become so chronic and so permanent, it had gone to the side gutter of the knee. And they don't have any genu variant or valgum too severely, but on scan, you can see they are really badly subluxed dislocated laterally. And their TTTG will be way out. And of course, Professor Zhang Hui will show the cases that in such scenario, a lot of patients, when you do their femur and tibia, there's a lot of malrotation and in combination to create this sort of scenario. However, in this case, we discussed with the parents and the kids in terms of should we do a femur tibia osteotomy to solve this, but parents prefer, can you solve everything on knee itself and don't cut the femur and the tibia. So we went on to address the issue on knee. So this was slight habitual patellar infection and finally become permanent in chronic patellar dislocation. So what are the issues here? Issue a very small dysplastic patella, very short quadricep. There was some form of dysplasia and there's increased TTTG distance. So what do we do? Address them. So we lengthen the quadricep, we release very bad iliotibial band laterally, and we reinforce NPFL and also do the TT transfer. So usually in such cases, when patella very subluxed and there are a lot of contracture laterally, the iliotibial band and fascia lata will be very tight. And while we are releasing this, we thought, why don't we create a more ingenious way? We actually harvest this in 10 mm sort of like diameter to use it as an NPFL graft later. So that's what we did. We release all the way until intermuscular septum. And then you can see that lateral side really, there's nothing left here. And then you can look how very tight. The moment you flex, this whole thing will pop out straight away. So we do a very extensive Z-plasty all the way up. And you can see that half of the patella attached to the quadricep. And that's how it's like. And having done that, when I only transferred to 15 millimeter TTO, the patella still dislocate. So at the end, we have to do a TTO of 30 millimeter and with this extensive quadricep plasty. The only patella was in its place. So this was like, you can see that immediate post-op, when we flex fully, the patella is perfectly enlocated. And this is what's like immediate post-op. We did a CT scan to show, compared to the unoperated side, you can see patella was very nicely enlocated. And this will make parents very pleased. And this is a post-op X-ray, lateral view. So in summary, all these problems, we need to address them in terms of assessing these kids and adolescents. And Professor Zhang Hui also tell you, make sure you look at Q angle, whether there's bad enough femoral and femoral valgus, and also bad enough rotation in tibia femur. I exclude all this. Having excluded all that, then you can look at address all these issues because all of them you can do surgically. You need to do the NPFL, whether TTTG need to be reduced, and trochlear need to be addressed, and finally whether your patella need to be distalized. So I thank you for your attention.
Thank you, James. So we're a bit over time, right? So we'll leave the Q&A sessions later on, right? So the next speaker is Professor Zhang Hui from Beijing Jishuitan Hospital, right? Department of Sports Medicine, right? Professor Zhang Hui is a good working partner of Professor Feng Hua for many, many years. And he's a real expert in knee surgery as well, particularly in meniscus as well as patellar dislocation, right? It's our honor to have him today to share the skills and knowledge of Jishuitan Hospital's sports medicine departments over the years, particularly in managing this difficult situation. Today's topic is about osteotomy in fixing patellar dislocation. So Zhang Hui, your turn. Thanks.
Oh, thank you, Patrick. I want to introduce something about the osteotomy in the patellar dislocation. And the first question is why we need the osteotomy. As we know, the patellar instability will always combine with some bony dysplasia, and but this, I think, this is not the most important reason. And what is the and we can perform different osteotomy in the patellar dislocation, includes coronal or sagittal or horizontal, different kind of osteotomy. But why we perform the osteotomy for the patellar dislocation? To our opinion, we think the most important thing is patellar maltracking, and I show this video is a recurrent patellar dislocation patient, and this is the J sign, and just as Professor James just called it, is dislocated in the extension. And to our opinion, we will call it is a J sign, positive J sign, and this one is a habitual patellar dislocation. That the patella will be dislocated when the knee flexed. So I think even both for the patella dislocate when the knee extension or flexion, I think for this kind of patient is a patella maltracking. And for this kind of patient, perhaps is a NPFL reconstruction only is not enough. So we think this kind of patient, they will need a osteotomy. If we ignore this kind of tracking of the patella, such as this patient is a bilateral recurrent patellar dislocation and a bilateral J sign positive, and for the left side, we only perform the NPFL reconstruction and the tibio-tubercle medialization. But we can find 1 year later, when this boy extension his knee, the patella will lateral transfer again. And so we think this procedure is not enough for him. And we can compare the CT scan pre-operative and post-operative. This is the pre-operative. When the knee extension, the patella will be dislocated laterally, and this is a 3D reconstruction. And after the operation, we can find the position of the patella is almost the same compared with the pre-operatively, and also the from the 3D CT. So we think for this patient, we perform the NPFL reconstruction and the tibio-tubercle medialization. That is not enough. And we perform a study to find what will be the high-grade J sign will be hazard to the NPFL graft. And we find if the patient have a pre-operatively grade 3 J sign, that means the high-grade J sign, that will be correlated with more NPFL residue graft laxity. If we only perform the NPFL reconstruction and the tibio-tubercle medialization. And we also perform the study to find what is the risk factor of the severe J sign, and we found 3 independent anatomic risk factor for the high-grade J sign. That includes the increased femoral anteversion, excessive external tibial torsion, and the patella alta. So for the first 2 rotation alignment, we need to perform the derotational osteotomy. And for the patella alta, we can perform the tibiotubercle distalization. So this is the reason why we need the osteotomy for the patellar instability. So I think the indication for the osteotomy in the patellar dislocation will include the these 4 things. And the first 2 is most important. That is a high-grade J sign in the recurrent patellar dislocation. And second one is the habitual patellar dislocation, just as the video show here. And sometimes the patient will have the patellar dislocation and combined with a valgus knee or hyperextension. And this kind of patient is, we can perform the osteotomy to correct the deformity. And the second question is how to treat the high-grade J sign. That means we can perform the derotational osteotomy or combine with the tibiotubercle distalization. And this patient is a 14 years old, left knee recurrent patellar dislocation and combined with a high-grade J sign. This patient is a little special because she cannot flex her knee because the patella will be dislocated. And each time she wants to flex the knee, she needs to push the patella back to the trochlear. And the first operation this patient undergone is only performed the NPFL reconstruction, and it's totally failed. And the tip of the physical examination is to how we can screen the anteversion, because I think for this kind of patient, we need to confirm the femoral anteversion is too large or not. And we can use the hip, the rotation of the hip to find if the anteversion is too large. And for the normal people, the hip of the internal rotation of the hip and the external rotation of the hip will be similar. That will be around 40 to 50 degree. But for this patient, we can find she has the excessive internal rotation of the hip. So that means this patient perhaps will have an excessive femoral anteversion. And then we can perform the CT scan to evaluate the torsion. And we perform the CT scan from the hip, knee to the ankle. And we can make the different slice overlap and to measure the femoral anteversion or tibial torsion. But we recommend to use this 3D CT. That will be let us to get a more precisely measurement of the anteversion or tibial torsion. So for this patient, we can find she has a femoral anteversion around 60 degree, and another side is 43 degree. So for this patient, we perform the derotational distal femoral osteotomy to correct the excessive femoral anteversion. And this is the preoperative. We put the scope in the proximal media portal to find the patella. We can find the patella when the knee extension. The patella will be lateral dislocated, and we can flex the knee until the flexion is around 90 degrees. The patella will be will be enter the trochlear, and this is we just after the derotational osteotomy without NPFL reconstruction, and we can find the patella will be located to the trochlear, to the center of the trochlear automatically. And this is a picture we just after the fixation of the plate. So this is pre-operative. We can find the patella will be, each time when she extension the knee, the patella will be dislocated laterally. And this is 1 year after the surgery. She can extension the knee by herself, and there's totally functional. And compare the CT scan and the pre-operative, the patella will be, when the knee is extension, it will be totally dislocated laterally, and this is post-operative. And this patient is 19 years old, male, and bilateral recurrent patellar dislocation combined with a high-grade J sign. And for this patient is different. He has a femur anteversion is around 25 degree, but the tibia side is very large. Tibia external rotation that will be around 55 degree. So for this patient, we perform the tibia side derotational osteotomy, and we can compare. This is the pre-operative and the post-operative, and different angle pre and post-operative, and also we have the picture of the pre-operative. The scope view, we can find the patella is the lateral side, and just after the derotational osteotomy, and the patella is almost in the center of the trochlear, and this is without NPFL reconstruction. And if the patient will have a patella aorta, we can perform the derotational osteotomy combined with the tibial tubercle distalization. And the last question is how to treat the habitual patellar dislocation. We use a little different technique from James, and we always use tibial tubercle proximalization to lengthening the extension mechanism, just as a video show here. And this patient is a severe habitual patellar dislocation, and the sky view, we can find the patella will be dislocated laterally, and this is the CT scan. If we push the patella back to the trochlear, and it's very hard for this patient to flexion the knee. So we perform the lateral release, just as James showed the video before, and we cut the we cut the adhesion between the patella and the ITB, and then we perform the VIO lengthening. But for the extensor lengthening, we use another technique, that is we perform the tibial tubercle proximalization. And then for this kind of patient, will be always combined with a fat pad contracture. So we need to release the fat pad even to the medial retinaculum. And at the same time, if the patient have a too large TTTG, we can transfer the tibial tubercle proximally and medialization. This is after the surgery, we confirm during the full range of motion, the patella will be stable, and then we can perform the NPFL reconstruction. And this is a final result. This 1 year later, the patient have came to my hospital, and to remove the hardware, we can see the patella is in the center of the trochlear. This is pre-operative and post-operative. So why we need to perform the osteotomy? I think the most important thing is we need to pay attention to the maltracking. That includes the J sign, just as the picture show here. Then this kind of patient perhaps will have a torsion deformity. So this kind of patient, we need to perform the derotational osteotomy. And sometimes the patient have a habitual patellar dislocation. And for this kind of patient, we need to do the combined osteotomy for the final treatment. So that is my topic, the osteotomy in the patellar dislocation. Thank you.
Thank you very much, Zhang Hui. Beautiful case, beautiful management, bro. Amazing. Thanks for sharing all these cases. It's not easy, but you handle it very, very well with the teams, right? So we are a bit tight in the time, so I will hand over to Dave to start the Q&A sessions because we have collected some questions in the Q&A box. So Dave,
Yeah.
so I would
you.
like to all the speakers to unmute yourself, right?
So thank you, James and Professor Zhang Hui, for reminding us that the patellar dislocation is not only about the NPFL, but all the bony abnormalities as well. So there are some questions in the Q&A box. And so I'm going to ask just all the panelists one by one. So there's a question on the use of quadriceps tendon as a graft for NPFL. Can I ask anyone in the panel uses the quadriceps tendon as a graft option? Maybe we start with
maybe
Zhang.
Dave, because of time, whoever used it, right, just let us know, right? And then you can give your opinion, right? Would that be okay?
Yeah, that's okay. Anyone uses quadriceps graft?
Seems no one using quadriceps tendon, right? James, you want to say something?
Oh, I basically I use it to almost for my those revision cases where you know NPFL has failed. Then but a lot of my friends in India and US they do it very well. So actually it's something that you know, especially in a place you don't want to use too much implants and all that. There's an excellent graft choice.
Yeah, but I agree. So quadriceps is a good option because it's fixed on the patella. I'm also aware that the Australians use it. The other question is how often do you do a lateral release when you do an NPFL reconstruction? We're not talking about the very complex cases that we saw with Professor Zhang Hui and James. You know, with NPFL, the question, this came from Ryosuke. Perhaps Kyung Ho can take it. Do you do a lateral release with NPFL?
Actually, I don't like the lateral release in case of the instability. Okay. So, and then there are not so many cases of a high grade of trochleoplasty. So in my case, the majority of patients is I only perform the NPFL reconstruction without the lateral release.
Okay. How about Ishan? Ishan, do you do a lateral release with your NPFL reconstruction?
My case is very rare, except some very like initial almost fixed patellar dislocation, very tight. I will try to release first. Most cases I did not do release.
Yeah, so I think the take-home message is that for most NPFL reconstructions, just isolated, there's usually no need for a lateral release. It's for the cases that you see in with James and Zhang Hui that they are really contracted that you may need to do a lateral release. Can I ask the panel, how often do you do an isolated NPFL reconstruction versus, let's say, NPFL reconstruction with a tibial tubercle osteotomy? So let's say, what is the percentage? Maybe we start with Nobo. Professor Nobo.
Thank you. Yeah, for ligament type of patellar dislocation, maybe 80 or 90%, I only do the NPFL reconstruction. For the habitual type, maybe sometimes we need to do the distal realignment procedures. So for the recurrent patellar dislocation, 80 or 90%. Yeah.
Would that be the number for all the panelists as well? Kyung Ho?
Yes, so agree.
Okay.
Yes, I searched my raw data a moment ago. So total my cases was 200 cases of NPFL reconstruction. Yeah. Only one case was combined tracheoplasty, and 11 cases was tibial tubercle osteotomy, and 12 cases was combined after femoral osteotomy. And I searched my raw data a moment ago.
Okay, thank you. And then just one more question. This came from one of the audience. With regards to, do you assess the length change of the NPFL intraoperatively? Maybe Ishan, you can answer this. Professor Chan from Chung Kung Memorial.
Yeah, express again, you mean the intraoperative check for NPFL?
The length change of the reconstructed graft, because I know I saw in your presentation you showed an isometric point. Yeah, so there's a change in length of the graph? Let's say when you move it from flexion to extension.
When I check, I do the isometric checkpoint. I find if position okay, almost no change. Maybe the minimum 1 or 2 millimeter should be acceptable.
Okay. Okay. Kyung-ho, same thing. Do you think there's any change in the graph length?
No. My target is the anatomic position. It's not an isometric point. So I fixed the graph in only 30 degrees. So I don't care about the isometric point.
Okay. Okay.
How about the others? Well, or personally, I don't think there's an isometric point for the NPFL. But of course, I understand that some of the people would think that there's an isometric point. Noble, do you think there's an isometric point for?
Yes, I choose the point according to the individual anatomic landmark. And so sometimes we check the length change, but usually I don't check. If we choose the correct point based on the anatomic landmark, for recurrent patellar dislocation, the graft is in tension in extension usually. So we have been very successful in most of cases. So recently I don't check the length change anymore.
Okay.
Okay. So thank you very much. So Dave, I think that's all for the Q&A sections. Because we want everybody can, go for dinner, right? We want to conclude this webinar, but before that, I have several announcements. First of all, I would like to thank all the speakers, right? James, Noble, Kun Ho, Yishan, and Zhang Hui for taking the precious time to join us. And also thanks for the EPCAS Secretarial Office and ITV support for that, right? Just a kind reminder, all these presentations are already broadcasting in the YouTube, and we'll post the link in the EPCAS webpage as well. Our Indian friends indeed has already live broadcast this webinar through the OrthoTV. So I looked at that there are over 100 people looking through the OrthoTV, while concurrently we have more than 300 people attending this webinar. So it's very good, right? Well, the next one will be again 3 weeks from now. This is a little bit away from knee. Next time will be about ankle, right? But it's still interesting for sports medicine. So please join. That will be on the 3rd of July, the same time, right? That will be moderated by Samuel and Hua Yinghui, right? And we have several speakers, Dr. Jody Wigan, Shinji Izumuto, Shen Huang Hen, as well as Pierre George from Espada, right? So very prominent speakers. So I'm pretty sure that you have a good time with them, learn a lot about the chronic ankle instability, right? The second announcement is about the next upcoming EPCAS Congress to be taking place by our Thai group, the TUSSM, which will be on December from 3rd to 5th this year. We are looking forward to that, and hopefully by that time the COVID-19 has gone. And please pay attention to that, and pay attention to all the deadline of the abstract submission, which will be on the 31st of August. So once again, thank you very much for all of you attending. So before we conclude these sessions, again, this webinar is initially introduced and suggested by Professor Feng Hua. We just want to play the video that we say the condolence as well as the thanks for Professor Feng Hua over these years for the contributions in the education of our knee surgeons in the knee, patella, meniscus, ACL, and so on. So I would like to conclude the sessions with the videos played as follows. Right? Thank you, Feng Hua. So I'd like to thank all the speakers. Thank you, Yishan. Thank you, Zhang Hui. Thank you, James. Thank you, Noble. Thank you, Kunho. And thanks, Dave, for helping to moderate the sessions. So we'd like to end this meeting. Thank you. Bye-bye. Good night.
Thank you.
Bye-bye. See you.
Bye.
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 If you have a,
Bye. Take care.
Goodbye.
Patrick, should we have a photo of everyone before you all leave? Do you have a selfie? Hey, where's where's Dave?
Dave,
Oh no, Dave is gone.
don't worry. Okay.
Yeah.
Now Kunho is taking.
Okay, can you take a selfie?
Very difficult to. I cannot.
I cannot. Can show.
It's okay, guys.
Also, it's alright. It's too bright. So my fellows will.
Okay. Okay, good. Thank you very much.
Perfect.
Okay.
See you.
Bye-bye.
Bye-bye.
See you.
Bye-bye.